Language is a key barrier for the use of generative AI in digital health solutions in low and middle income countries. That's the findings of a white paper done by the Stanford Center for Digital Health. They looked at 5 case studies, sent out a survey, held a couple of roundtables, and interviewed a bunch of experts. Now I found this surprising for a couple of reasons. First of all, the companies that build generative AI would have us believe that language barriers are no longer an issue, that large language models have solved all the language problems. It's clearly not the case. And language is often not considered in reviews of health programming, so it was really nice to see those questions asked here. But what I found most surprising were the results of the survey. The respondents chose language barriers as the key barrier over other issues like internet connectivity, digital literacy, or cultural context. And that's surprising because when rolling out digital solutions, internet connectivity and people using smartphones are often seen as the key barriers. And I'm wondering if that's starting to change a little bit, and the lack of resources in most languages is starting to become a bigger problem as we roll out more digital solutions. All 5 of the case studies were around behavior change communication in health, and they were all in pilot phase or had just finished pilot phase and were looking to scale, and that's where the language issues were coming out. They all found that generative AI was useful with some caveats. They said that there were a whole lot of other things you had to get right besides just the language model. For example, using human-centered design, so working with the intended users to identify problems and potential solutions, and then working with them to develop the tools was seen as critical, and government buy-in was seen as crucial. Some of the risks they pointed out aren't going to be surprising if you've seen any of my other videos or talked to me in person. Hallucinations were of course seen as an issue. Large language models are going to hallucinate, and practitioners need to determine what their level of tolerance for that is. In health programming, it could be quite serious. Because most language models are built English first, they often reflect those cultures and those contexts. So they sometimes get things like slang wrong. One person said that in Nigeria, people were talking about having an empty chest, and the language model was interpreting that to mean depression. In Nigeria, having an empty chest is sometimes how chest pains are described. So a completely different symptom, and therefore a completely different recommendation or solution. Another person talked about how the context was important. She gave the example of a woman whose baby had a fever, asking a model what she should do. And the model said, take the child to your local pediatrician. She lives in Nairobi, and most people in Nairobi don't have a local pediatrician. A better response may have been to call a nurse or go to the clinic. Now, I thought this was a really great review, a really great white paper, some good recommendations. I do wish that they had been able to talk to some of the end users, because I think that would have given a bit more richness to some of the issues and barriers that they talked about. I also wish I understood a bit more. They didn't really talk about whether it was machine translation or automatic speech recognition that was the barrier. And some of the case studies talked about building their models in relatively higher resource languages like Hindi or Swahili, and then fine-tuning for lower resource languages. And I wondered if that's where the language barriers were coming. But overall, I thought the recommendations were great. It was a really interesting white paper, and I hope that donors, governments, practitioners read it and take the recommendations into account. And that's what's interesting in the resource language tech.